Welcome back, everyone, for another episode of the AltMed podcast series. It's Andrew Dowling here, my co-host Mitch Kurtz, and
Hello.
we've been looking forward to this episode for a long time now. I know we've only been doing this for a little while, but we've got David Feng, Dr. David Feng, the co-founder of Cannadoc, on this episode, and we are going to tap into David's wealth of knowledge as a GP with a special interest in medical cannabis. David, welcome to the podcast.
Thanks, guys. Thanks for having me. I'm super excited to be here.
It's an
Excellent.
absolute pleasure to have you on. Always have some fantastic chats with you, and always look forward to hearing what's going on in your experience in the industry. Is there anything we might have missed you'd like to add to a little bit of your
introduction? Well, I was just thinking, if anyone out there is enjoying the podcast series so far, then we would encourage you to like the podcast. We've got a page on Facebook now, I'm led to believe. So please tell your friends about it. We really hope it's a useful informational resource for you and for your network. And if there's any information that you want us to talk about on the podcast, just hit us up, and we're always open ears to suggestions. So I think we might just dive straight in. So Mitch, I'm going to let you kick this one off.
Absolutely. Well, seeing as we have our first GP on camera now, I guess we're really looking at what you're experiencing on a day-to-day basis when you're working in in your capacity as a GP, directing people to cannabis products or dealing with people with different indications that are coming specifically for medicinal cannabis. And we want to know a little bit about, maybe first start with an overview of the types of indications or the things that people are coming to see you about as a very general step.
Okay, well, I guess because we run a predominantly sort of medicinal cannabis driven clinic in Australia, basically in Melbourne, we often take a lot of referrals from doctors and patients, sometimes self-refer for all sorts of different indications. The most common indication we usually see in our clinic is chronic pain, some sort of chronic pain that's been there for a long period of time and it's not responding to traditional frontline therapies. And I would say like 2/3 of our patients or more would probably have some sort of chronic pain component to their symptomatology. And anyone who's gone through chronic pain will also know that, when you have a lot of chronic pain, you also have a whole bunch of other symptoms that tend to coincide together. Chronic pain tends to wear people down emotionally and physically as well. So they get a lot of fatigue, they'll have trouble sleeping, they'll often have anxiety and depression with it. So it's often, a myriad of different symptoms that we're treating, but I would say the overwhelming majority would be chronic pain based. After chronic pain, the next most common indication is probably anxiety plus or minus depression. There is a lot of psychological symptoms that we use medicinal cannabis for, including PTSD, sometimes behavioral issues and autism in children. We're seeing good results in insomnia. We're also seeing a lot of movement disorders that respond quite well to medicinal cannabis, like Parkinson's disease, Tourette's. Multiple sclerosis is probably the biggest one that tends to respond to that. And a small proportion of our patients will end up being, unfortunately, palliative care patients or patients who've undergone treatment for cancer therapy, so like chemotherapy, and they get like a lot of severe nausea and vomiting. That tends to be a symptom that is well treated with medicinal cannabis. Yeah, so those will probably be the biggest ones off the top of my head.
Yeah, that's it sounds pretty consistent with the information we hear from the medical community. Especially, we had Asper from DeCastro on a couple of weeks ago who said a very similar thing. Was really kind of in that chronic pain and then anxiety, sleep realm. A lot of people coming for kind of insomnia, those types of those types of things. Yeah, in your experience dealing with chronic pain and all the aforementioned indications, do you see, what's the kind of breakdown that you're seeing between THC and CBD in terms of what you would prescribe? Is it more THC dominant stuff, CBD dominant? Is it a hybrid? What are can you just take us through that?
Yeah, I like to think about the different products into, 4 distinct categories. First and foremost, I like to think of CBD in an isolate form, so just purified CBD without any of the other cannabinoids in there. And I like that one because it's got no THC in it, and it's pretty purified, and you don't run the risk of driving or cognitive impairment with the THC. So anyone who is telling me that I have to drive, I'll probably say, look, the only one that we can safely put you on from a legal perspective is CBD, probably in the form of an isolate, because CBD that has small traces of THC may be detectable in a driving test. So I think about CBD alone in an isolate. I often use that in anxiety, patients with anxiety, or sometimes sleep disturbance. It works quite well for. It also works really well in children, where you don't know what the safe level of THC use is. And I mean, I've treated quite a number of children with autism or ADHD, and CBD tends to work quite well for these behavioural type symptoms in autistic children. CBD alone can also be really good in severe epilepsy in children as an isolate, but unfortunately the doses for that are significantly higher than what an adult would take for, say, anxiety. So I think about the isolate as number 1. Number 2 would be CBD predominant preparations, or full spectrum CBD oil, where it may contain a little bit of THC in it. I like those ones, as I find those ones to be superior than CBD isolate. But I generally don't recommend those if people are using or wanting to drive with it. But that would be my front line for, again, the anxiety or mood disturbance type issues. CBD as a full spectrum or broad spectrum is also very good for fibromyalgia. So that's one of those chronic pain conditions that doesn't tend to respond to traditional frontline therapies, but responds really well to medicinal cannabis, even just as a CBD isolate or full spectrum, broad spectrum CBD. So that's category 2. And then category 3 is probably the most popular or most frequently prescribed preparation, and that would be like a 1-to-1 ratio of CBD to THC. And those patients, that preparation I use predominantly for chronic pain issues. So fibromyalgia works really well for. It works really well for all sorts of chronic pains, like whether it be neuropathic pain or sort of mechanical type pains, like your osteoarthritis or musculoskeletal type pains. It's a 1-to-1 ratio works really well for as well. A 1-to-1 ratio also works really well for sleep issues, chronic insomnia. It also works really well for multiple sclerosis, where people have, in multiple sclerosis, the classical symptoms are a lot of pain, chronic pain, as well as muscular spasticity, a lot of muscle spasms across the body. And the THC in that helps with the pain as well as the spasticity at the same time. So that a lot of people get really good relief from those symptoms with a 1-to-1 ratio. And then I think about the last category is the high THC, very low CBD type preparations, and I would use those where pain levels are exceedingly high and they're not really responding well to a 1-to-1 ratio. So you would step up that sort of ladder of therapy, and the high THC is really good for cancer pain. It can be really good for sleep because THC can also often be it can induce drowsiness, and people can sleep a lot better when they take it. And high THC concentration is sometimes really good for severe neuropathic pain as well, where the 1-to-1 ratio hasn't worked very well. So those are probably, I would split the different preparations along those 4 main groups.
Well, that's really, really helpful, David. And I'm picking up on, when a patient comes to see you and you're trying to figure out which of those 4 products might be suitable for them, going back a step to this issue you raised before, where a patient needs to have failed a first-line therapy. I think most people out there can probably get their head around the concept of somebody being prescribed, say, an opioid for pain and not responding very well to that. But are there other reasons, such as side effects, that can open up the possibility of medical cannabis treatment? And perhaps maybe you can just speak to that issue of the first line therapy failing and some of your clinical observations with that.
Yeah, and this is a guidance from the TGA, the Therapeutic Goods Administration. They don't want doctors prescribing medicinal cannabis as a frontline therapy. They don't specify exactly how many treatments you've had to have tried and failed, or whether you would have needed to justify any side effects and things like that. But what tends to happen is when you access medicinal cannabis for patients, you actually have to justify to the TGA as to why you're using this in the form of an application, a TGA application, and you have to get a permit for the patient before they can access it. So in your justification, say if a patient came in with chronic pain, fibromyalgia or whatever, oftentimes these patients have had the pain or symptoms for long enough. They've tried a myriad of things under the sun, paracetamol, non-steroidal anti-inflammatories. They would have tried maybe steroid injections. They may have tried opiates. They may have tried anti-epileptics or anti-seizure medications that are useful for neuropathic pain, and other neuropathic pain medications like Lyrica, gabapentin, that sort of thing. So, if you have 2, 3, 4 things that the patient's tried, if they've only got partial relief or they get side effects from it, and you feel like their quality of life is still not good despite these therapies, then you can absolutely make a justification to the TGA that you want to try this for your patients, and it's up to the TGA to decide whether that is a good enough justification. So, and sometimes as simple as the patient getting side effects, or the patient being really worried about this medication, having to take this medication for long term, and whether it might be addictive or worried about its potential side effects, that might be enough of a justification to the TGA for the TGA to say yes, and we're happy for you to try this. It doesn't have to have, you don't have to have gone through, half a dozen different opiates, or half a dozen different pills that potentially could give you side effects before you qualify for that. And the other example I like to give is say for anxiety. We see a lot of patients that respond really well to medicinal cannabis, and in order to get that justification, it's not like we try to make up. I have to be very careful here. It's not like we're trying to come up with reasons to get patients on medicinal cannabis, but if we see a justification in our consultation, then we'd be like, that makes a lot of sense. You've tried a few things, it didn't work. Maybe this is the next thing to try. And when we talk about anxiety, classically, a lot of patients have tried meditation, they've tried exercise, they've tried seeing their psychologist for cognitive behavioral therapies or other therapies. They may have tried antidepressant medications, SSRIs, that sort of SNRIs, other medications that can help with anxiety. They don't have to hit everything on that list before you say, we're going to try for an application for you. But you have to be pragmatic about it. I think you just have to say, if the only thing you've ever tried is exercise, or the only thing you've ever tried is meditation, that might not be enough to justify it. But if you put a cluster of 2, 3, 4 different things that you've tried and you've genuinely given it a shot and it's not worked for you, then I think the TGA are pretty open to our patients exploring medicinal cannabis.
Yeah, and it's also it's interesting how each of those alternative pathways or maybe word it differently, those alternative treatment options, exercise, dieting, cognitive behavioral therapy. I mean, surely at each point where that was considered for that patient, that is itself, there is a clinical justification to be had there. So it represents perhaps just another juncture in the clinical treatment of a given patient. But then let's say that the TGA does approve someone getting access to medical cannabis because the doctor has justified the case. I guess my next question is around what that looks like. So, for example, if you have a patient who might have dependency upon opioids, do you tend to run the cannabis treatment in tandem or in concurrent with that opioid treatment? Or is the idea that you substitute out the opioids and sort of phase in the cannabis if it's working? How does that actually look? Because I imagine that's fraught with some difficulties with, patients withdrawing from, say, antidepressants or opioid medicines. How does that look in the clinical context?
Yeah, that's a good question. When people are using opiates long term, there's almost certainly going to be some degree of dependency or tolerance. They're going to need, it's very common for patients to need higher and higher doses to get same effect with opiates, and same with benzodiazepines, and they often develop a dependency to it, and you can't stop these medications like cold turkey. Otherwise, people will go through withdrawals and they'll feel miserable, and they can make themselves quite sick. So what I like to do is keep the patient on the same opiate regime or a benzodiazepine regime, whatever it might be, and just add low doses of medicinal cannabis, and see if we can get some improvements in their symptomatology. Maybe reduce the pain level a little bit, maybe improve their appetite, maybe improve their sleep a little bit, and then get them to a new equilibrium where they're feeling better in themselves. And then, once we've optimized the medicinal cannabis side of things, then we can really start thinking about tapering off their other medications. Opiates and benzos are ones that you want to do that slowly on, just because of the risk of withdrawals. And most people, will do that quite safely. Once you get the medicinal cannabis on board at a right level, they can then sort of titrate off opiates. And I've seen people do it quite successfully time and time and again. And unfortunately, even if you warn patients, a lot of patients, because they can get such good benefit from medicinal cannabis, and I'm not saying that it works for everybody, okay? Like it does work for a large proportion of patients, but the patients that it works really well in, there's often an issue with the patient wanting to stop everything really quickly because they feel so much better with it. Opiates, benzos, they all have potential risk for side effects and things like that, and like constipation, drowsiness, that sort of thing. And people want to come off it quite quickly. And you have to actually warn them that, no, you try and maintain the same regime you've been on. They've probably been on this regime for years. You need to stay on this until we've had a further discussion to slowly wean you off it. And once they understand that, then it's pretty straightforward.
That's really quite good. I realize I'm taking the microphone for a bit, Mitch. I'll throw to you for the next one. But I just had a question about that you hear reports of people sort of who have maybe tried CBD or medicinal cannabis overseas. They enjoyed it. It might have helped a condition, but then they realize that perhaps the regulatory structure for getting access to it in Australia is a bit harder. Just from a doctor's perspective, I'm just interested, have you come across this in your practice where someone says, the reason I've come to you is because I've tried CBD or something else overseas, and is that a basis upon which you could provide a clinical justification for a patient, or is that a bit more in the gray area?
Having tried it in the past,
or sorry, I should say as well, black market as well, perhaps might fit this discussion too.
Yeah. To me, if someone's tried it in the past and they've had, done really well on it, or they didn't get any side effects from it, it helps me make a decision as to, would this work well for you? And so, yes, it helps with the clinical judgment side of things, but, we still have to abide by the TGA guidance. You still have to make a justification to the TGA that there aren't any simple basic therapies out there that the patient can access in Australia that that allows them to get the same sort of effects. And look, I hear this all the time. You know, patients are accessing CBD oil or CBD THC oil either overseas, or they're buying it, you know, online, and they're getting it shipped into Australia and trying and getting some really good results from it. And I say, great, but you're doing it illegally, and we can't condone that sort of thing. And we still have to, as practitioners, still abide by what the TGA has guided us to do, and we still have to, you know, base it on evidence-based therapy. Yeah, so there is a bit of a grey area in that regard, but I still like to show to the TGA that the patient has tried and failed other therapies first.
Yeah, I can't imagine you could go on the SASB portal and just say, oh yeah, patient has had cannabis in the Netherlands, hook him up down here.
Exactly. Yeah, the patient smoked some, he felt great, and we're going to give him some now. I don't think it's going to work that way. Not until it becomes recreationally legal, I think.
Yeah. In saying that, obviously you do find that there is a difference between some illegal products. Legal products, obviously, some are not what they purport to be. Now, looking more in the legal market, which you've got much more experience with, without getting into any brand specifically, do you see quite a bit of variance in the products that are actually in that market in terms of how effective they are, or seemingly anecdotally efficacious they are?
Yeah, actually, that's a really good point you raised, and yes, the short answer is yes. Depending on the genetics of the plant that they derive the medicinal cannabis oil or flower from, you can get quite varying results. And at the moment, it's a lot of trial and error to try and find the right, cultivar or strain for the patient that works best for them. Not even just going back to the ratio of the CBD to THC or the patient is using, but even the brands. We just don't have enough scientific know-how or research that's been done to show which strain will work best for which specific condition or in which patient demographic. So right now it's really just trial and error. We try one brand at one concentration. If that doesn't work well, we may switch to a different concentration. If that still doesn't work well, we may switch to a different brand. And right now, a lot of companies are basically, it's a turf war right now, and patients are basically judging by price, and clinicians are as well, because that's probably the biggest hurdle for patients accessing medication, the expense of it. And so it's really hard to, as a clinician, to decide which product for the is likely going to be best for that patient. You have to judge it on price, on where it's cultivated or manufactured, whether it's GMP approved, and so there's a lot of factors to come into it. And right now, I don't think there's a good flow chart of optimization of what product is best for what patient.
Are there any trends though you might have seen in your experience, like say specific regions of the world type? So obviously that looking cultivate.
Mitch, I'm sorry to jump in here, but it's just lagging a little bit on your end. I wonder if you can perhaps just jump on the old hotspot. But I think Mitch was just querying around whether or not there's any trends with there are specific regions in the world where the product's going to be good if it comes from there, or particular growers. We don't have to name any names of product providers. We tend not to do so on the podcast anyway. But any trends that you've observed with products?
Yeah, and obviously we would
not supposed to be. Yeah.
Oh, sorry, I'm obviously lagging. But we'd obviously not be talking about isolate products, would we, in this vein? Because isolate would not really matter where the product's from or what strain, because it's literally just that one compound.
Mm, mm. Yeah, and that's a good side point. You know, we know that, you know, full spectrum or broad spectrum products are probably going to be more efficacious than CBD isolate. But from a geographical perspective, I probably, even though I've prescribed it for a lot of patients, I don't get a good feel as to which geographies have the you know, a better strain or more effective type cultivar. I'm not entirely sure if it's geographically driven. I think it's more about like the underlying genetics of the plant that they're using to grow to produce their medicinal cannabis out of. And I think it will be very company specific in how much R&D they're spending on this stuff, and trying to work out which is the best genetics. And I haven't got a good feel as to, you know, how to decide by geography at this stage. Maybe you guys can, you guys have some experience and you can comment on that.
We could, but it would possibly not be the most neutral comment. So we'll leave that one for another time.
I assume, Mitch, at some point we will have an episode of this where we'll do a deep dive into, you know, cultivation practices, extraction methods, and that sort of thing. But we'll spare you all of that now, David, because we'll stay.
I mean, David's correct in the sense that you can grow different genetics from different regions in many parts of the world, given you've got the right greenhouse, you've got the right conditions, you know, if you're doing an outdoor grow. So he's not wrong in that respect. I think maybe the point we were trying to get at is there's different regulations in different parts of the world, which mean that the different quality standards dictate the types of products that might come from specific regions. But in saying that, I think we can probably move on to the next part, which I wanted to know specifically was just the general questions that, well, two things, the general questions that you get asked. What are like the top 3 questions you get asked by patients? Like, just so we can demystify and let people know from the outset, you know, avoid them having to ask the next doctor the same question, whoever's tuning in. And then on top of that, I've just gone completely blank. I had my question in my head, but maybe answer that first and I'll come back to the next question.
Top 3 questions. One of the top ones will be, will I get high from this? I hear this, you know, every other consult, you know, am I going to get high? Because most patients, when they come and see us, they don't want to get high. You know, it's only a very small proportion of the population that actually want to use this recreationally. Most patients are actually after relief of their symptoms. And they've often heard good things. That's why they come to us. So will I get high? And I always tell them, look, there is going to be a dose where people will get high from, you know, like they can get high from. We know the dose to get, you know, medically speaking, we call it euphoria. There will be a dose where you get euphoria, and everybody's threshold to getting that is different. If you've never used it before, you know, your threshold is going to be really low, you know, and if you exceed that, you might get dizziness, you might feel euphoric, you might feel sort of spaced out and buzzed, or whatever, stoned, whatever words you want to use. And you might get the munchies and you might get quite drowsy afterwards. But the good thing is, you know, when we administer medicinal cannabis, get people to use it, we always start at a really low dose, you know, a dose far below what theoretically should be causing you to get high on. So, you know, say, let's say on average, most patients may need to take, you know, 30, 40, 50 milligrams of THC or more to get high. We would start at levels at 1 to 2.5 milligrams. So, you know, maybe 1/10 of or lower of a dose that to get people high, and we titrate very, very slowly, and we find that the therapeutic level is generally below the level that you would get side effects from if you titrate it slowly like that. And, you know, even if you were to get some side effects at really low doses, most patients tend to tolerate it over time. So if there's mild side effects, you know, some doctors will probably say, you know, like if it's very, very mild side effects, maybe just continue on this really low dose for a few days, and it will generally settle down. Your brain gets adjusted to that, and you know, the therapeutic effects will continue to be there, but without the side effects. And then you can titrate further if you need more therapeutic effects, and you can readjust to that next level. So that's probably the most common question I get, will I get high? But most of I would say the overwhelming majority of our patients will not be getting high. I think if the patients are getting high, they're doing something wrong.
And do you ever have a minority of patients that are seeking to get high, and when you disappoint them by saying that it's likely this CBD medicine won't get you high, that you're sort of met with a disappointed patient? Or
that's a good point. I forgot to mention that the CBD doesn't cause people to get high, and then it's the THC that gets the people high. I think we pre-screen our patients really well. We often get a referral from the doctor, from the treating practitioner or the GP, and we ask them, do you have a concern that this patient might is going to be using medicinal cannabis or wants to use medicinal cannabis? And then there are things you do in the consult. You tell them about the costings, the price, how hard it is to access and how to take it, and you generally get a feel of whether people are seeking it recreationally or not. We don't get very very few patients seeking it recreationally, because I think they talk amongst themselves and they know that medicinal cannabis is actually far more expensive than recreational street cannabis. So what's the point for them? Whereas the people who come to us, I would say 95% plus will be people really using it genuinely or wanting to use it genuinely for therapeutic purposes. So, but if I get a sense that someone's wanting to use this recreationally, I mean, I'll just tell them, look, there's no way we can help you access this, because this is not what it was designed for. Medicinal cannabis is being used as a medicine. We're not here to get you high, and we can actually work if somehow they get through that net, that safety net, and they get a script off us. The good thing is you can work out quite quickly how much they're using by how quickly they come back to get a repeat script. So we usually only give them one script, one bottle at a time, and initially, just to see how quickly they go through it. And then you work out the dose that they're taking. And if they're taking far more than you expect them to, then look, this person is probably using this recreationally, and we probably should be stopping it from here.
Yeah, interesting. But that actually, I think you brushed on the other question I was going to ask, which is that diligence piece, that as a GP prescribing cannabis, or especially at a place, that at a clinic that is, has a kind of specialization to some degree in cannabis specifically, or is at least, dealing with cannabis groups regularly. Your requirements to speak to, say, a patient's regular GP versus just seeing somebody off the street as a GP. Love to know a little bit about your process there in terms of that screening process. I know that you require referrals in a lot of cases. Is it always the case? Do you have to have a referral? What's kind of the situation there?
Yeah, and if I can just tack on to that, this idea of someone just choosing to go to their regular GP to get a conversation happening around medical cannabis versus coming to a doctor such as yourself that has a special interest. Do you need the referral from the original doctor? And as part of that screening process, I know we've just given you a lot to answer, but if you can also speak to the extent to which you ask about a patient's mental health history and how that plays into your clinical experience and what you might actually do with that information.
Yeah, so is it absolutely necessary to have a referral? No, there is no real legal requirement that we have to get a referral. We would like one, and we used to run on the basis that every patient must get a referral, so that to help us, it's for information gathering. Basically, we like to get a referral from the doctor to basically tell us that the doctor is comfortable for us to have that discussion with the patient if they wish to, or if they qualify for medicinal cannabis. So it was more of a, are you okay? Are you the referring doctor okay with us using this stuff? And if the answer is no, then we probably prefer not to do it. and two, it was to get, gather information on like say a health summary or some scan results or some blood results that might be pertinent to the consultation. And so that reduces the amount of sort of investigations that we need to do to decide whether the patient is appropriate for medicinal cannabis. So no, don't need a referral. We've started to become a little bit more lenient on not asking for a referral if so what we started to realize is patients would go to their doctors and their doctors would be completely against it. They wouldn't even consider it and basically just scrunch up the referral pad and just throw it away basically and say, no, I'm not doing this. Not even wanting to open that discussion up for patients. And so that was proving to be a hindrance for a lot of patients, even though it was their decision to make. The doctor would take that decision out of the patient's hands. And whether you agree with that or not, it is up to the doctor's discretion as to what therapies they want to treat their patients with. So, obviously, patients can't just walk into any doctor and demand a specific therapy. So, and so I see both sides of that.
Although, can I just jump in and ask, when a doctor is vehemently opposed to medical cannabis, and I presume you've met a few, probably not at the medical cannabis conferences you've been to, but I'm just interested, what do those doctors, clearly if a patient's coming to them seeking some sort of level of clinical justification for trying it, then they're there because something that doctor has currently given them isn't really working for them. Either they're not getting efficacy from the product or then they've got no side effects. So even the most sort of, shall I, for want of a better term, conservative doctor that chooses to sort of disregard any potential therapeutic benefit of medical cannabis, they're still in a tricky situation in that regard, in that they are dealing with a patient that isn't happy with their current treatment plan, right? So does that then mean that doctor has to explore perhaps other treatment options that might be considered more traditional or conventional?
Yeah, exactly. I think, if a patient raises the issue of a therapy with any therapy, it could be medicinal cannabis, could be anything else, with the doctor, I think the doctor has to make a judgment themselves as to whether they believe this therapy might be useful in this, and is this the right setting to be using this. If they don't feel like it, then they've got two options. They can refer to somebody else who may have a better grasp of what that therapy could do. So obviously, if someone comes to a GP about an ankle fracture, then the GP may not be the right person to be able to fix the fracture. You may have to see an orthopedic surgeon. It's the same sort of thing with medicines. If you're not comfortable with that medicine, you may want to get the patient to see somebody else who is comfortable with that. So that's option one. Or option two is you suggest a different therapy. The issue comes where the doctor just goes flat, no, I don't want to, this is not a right therapy for you, and they don't have a good justification for it, or don't have a management plan that sort of helps the patient move forward in what they want to do, or what they want to achieve. And we see that quite a lot. It happens in all sort of industries, I suppose, but it can happen a lot.
That happens? Or why would a doctor just be a flat no in your opinion or in your experience?
There's a few reasons. First one is probably there's still a very strong stigma around medicinal cannabis. I think most doctors will be fearful about the things that they hear on the media or that they've been taught by other people or other colleagues of them. The usual stigma, there's stuff that you guys hear about, it could be addictive, it's a gateway drug, it just leads them to dependency, it can cause schizophrenia, all sorts of these stigmas, which all in all, most of these have been disproved. I think pretty much all of these have been disproved.
And it's difficult to argue that opioids are necessarily safer, quote unquote, but yeah.
It's extremely difficult because we know, I don't know exact numbers for Australia, but something like 70,000 Americans die every year from pharmaceutical grade opiate overdoses. And these are prescription medications. So the medical fraternity, I believe, has something to answer for when a lot of their patients are overdoing their medicines and actually sort of accidentally inducing lethal doses, and it's extremely scary, and that number runs in the thousands in Australia as well. I don't know the exact numbers, but it's terrifying. Opiates are, I think there's a trend to realizing the medical fraternity is starting to realize opiates aren't a good long-term therapy for chronic pain.
Yeah.
But it was all they had, and also it was promoted like crazy by Big Pharma, unfortunately.
Is there such a thing as a lethal dose of medical cannabis?
Yeah, good point. There, nobody has been able to. There's been no documented case of a lethal dose from pure cannabis alone. Obviously, cannabis, if it gets people a bit high or they get cognitively impaired, and they were driving, they could certainly hurt themselves. But from a direct overdose of cannabis, there's been no single reported case. And that's completely, it completely flips the script compared to opiates or benzodiazepines, where and alcohol, all these other medications or things that people take can have lethal doses. You compare that to over-the-counter paracetamol. A lethal dose is 15 to 20 tablets.
Yeah,
and children can buy this off the counter and accidentally overdose them, and we say that's safe. And yet, if you consume, a full bottle of medicinal cannabis, you might get some side effects, but you will not die from it. And I think that's something that people don't realize yet. And I don't think the medical fraternity really sort of touts that enough. To say that the safety profile is off when it comes to opiates. Opiates not only can cause a lot of side effects, but there is potential for lethal ingestion.
I think it's, if anyone is watching this who is regularly taking opiates, I think that the information you've just provided is really, really quite valuable in just sort of saying, look, there are other treatment options available, and it is worth exploring that because of those potentially damaging long-term effects, which you've alluded to.
In saying that, I think it's always good to round it out with, especially from the doctor's mouth, adverse events or things that you do see from cannabis that maybe don't always end in the desired outcome. Yeah, for sure. Absolutely. Good point, Mitchell. I think we got to talk about the two main compounds of medicinal cannabis separately, because we often find, like when people take, say, CBD alone or high CBD, low THC preparations, they don't really get too many side effects. CBD on its own is very well tolerated in the general patient community. I think most common side effects will be occasionally some mild nausea, a little bit of lethargy or sedation, and maybe some upset stomach, like a little bit of diarrhea and that sort of thing. But those tend to be quite transient and resolve themselves over a few days, and they're usually very mild. I would say 9 out of 10 people will get pretty much no side effects when they took CBD on its own. It's the THC that you have to be a little bit more careful about. THC, at low doses, most often when we start people at low doses, they don't feel anything, and then as they get higher, the side effects will be dose dependent. So the bigger the dose you take, the more potential risk for side effects you might get. And the most common side effects will be like dizziness, drowsiness, increased appetite, and sedation. What else? Occasion, and the more you take, the more risky it is to getting high, basically getting stoned. There's a phenomenon that a lot of, let's say, young recreational users will understand as couch lock, where you're awake, you've taken a lot of THC, and you basically are on the couch. You can't really move. Like you don't have any motivation, you don't have the energy to get off the couch, and it's like that quintessential stoner look. You're sitting on the couch and you don't really do much. Yeah,
Mitch, have you ever experienced couch lock, Mitch? I'm curious.
I've heard of it, actually. I've heard of it. It's
I couldn't imagine Mitchell would have experienced something like that.
I think you heard of it from me, Mitch, actually.
They call it, actually, that's how they sometimes separate sativa and indica, and they say indica couch. And to note that that indica strain is more likely to give you a sedative reaction as opposed to a sativa, which might be a bit more cerebral.
But I mean, all of that, because one thing I also wanted to touch on was the monitoring role that you play in a patient's treatment. I imagine, so do you hear about that, any adverse events when you schedule a follow-up appointment to see how one of your patients is going with medical cannabis?
Yeah, we do. We usually advise the patient, and we either email the patient or give the patient a dosing diary. So we give them the regime. We tell them how to take it. How, like, every a few days you might increase the dose a little bit, and you monitor your own progress over time. And we review patients on a regular basis, and we look through the symptom diary, basically how well the pain's being treated, how well they're sleeping, their appetite, their mood, their weight, that sort of thing. And they try and keep a track of all of these things, and to try and get a gauge of whether it's working or what side effects they might be getting. So, and we will often tell patients, if as soon as you get side effects, let us know, and we'll have a discussion about that, whether to bring back the dose a little bit, which is quite easy to do. They just drop the dose and they feel a little bit better in themselves, or they just tell them to completely stop it and try a different formulation. But the monitoring is very important, more from a compliance perspective, because if they accidentally took a dose that's 5-10 times bigger than they would normally, they might just get quite stoned and quite high, and go for a Big Mac meal in the middle of the night, and then go for have a great sleep afterwards. But
hopefully not drive through. Just
maybe get someone else to get it for them. Yeah.
That sounds like a very
Uber eats it.
very dangerous side effect. A Big Mac meal, actually.
It can be. Yeah. I'd imagine heart attack risk and stroke risk might go up. Well, people on regular medicinal cannabis.
That actually ties into probably might be one of our last questions, I imagine, because we've kept you for a while now. But very much interested in your experience, contraindications and drug interactions. What considerations are there that you see? Who should be really kind of double or thinking about whether it's right for them in those situations?
Absolute contraindications will be pregnancy. We have no idea how it affects the unborn baby, so it's a no-no for a pregnant woman, or for lactating women, breastfeeding women. We say no. We just don't have enough safety data around it. Then there's if you've got unstable heart disease or severe liver disease, it's probably not a good idea to use medicinal cannabis. Well, unstable heart disease, THC is probably contraindicated. The reason for that is THC. I don't know if you guys have ever tried THC, but according to the literature, THC can induce a little bit of anxiety at high doses, and that can elevate the heart rate, cause palpitations, and it may destabilize someone's unstable heart rhythm or heart disease. And medicinal cannabis is processed in the liver. So if your liver doesn't work very well, probably not a good thing to be using it. It probably has to be pretty severe liver failure to warrant definitively not using medicinal cannabis, but that's another contraindication. And then there's psychiatric contraindications. So we know the literature has documented that recreational users using really high levels of THC in really young people, they may unmask schizophrenia. Not like, so if they were already prone to schizophrenia, say with a family history, naturally 1% of the population is prone to schizophrenia. If you're young, under the age of 25, and you took recreational cannabis at really high doses with really high THC regularly, your risk of getting or unmasking your schizophrenia goes up. It may not actually be an increased risk overall, but it just may unmask it earlier than you would have naturally had it. So because of that evidence, we say, even medicinal cannabis used with THC in young patients, we would prefer not to use THC in pediatric patients or patients under the age of 20, 25, that sort of thing.
Yeah. And just on answering that, question around whether we tried THC. I wouldn't want to ruin my reputation by telling people I hadn't tried it. But that's what happens when you
we have slightly different social circles, I think.
Well, having lived in the United States and working on farms and being surrounded by the culture, it's just a totally different approach to the substance. It's you walk in and grab it as though it were a bottle of wine in Washington State or Colorado, where I was. So
I'm reliably informed that you consumed it as though it were a bottle of wine, but anyway, I
think in all honesty though, like, we're probably the last generation to really know that cannabis is illegal, from any perspective. I think, in 5, 10, 15 years, how long it may take, recreational medicinal cannabis is already legal, but recreational will be that way. And I think it's going to be a wave across the world like that. So it's going to be something that people will be able to buy, at a dispensary, at a pharmacy, at a supermarket, maybe even like down the track. So,
you can get it in Aldi in Europe now. Like,
I imagine
things are changing when you see it open up in Southeast Asia, like Thailand, for example. Things are changing.
Yeah, but isn't it terrifying that a few years ago people being picked up in Thailand or Southeast Asia, Indonesia, somewhere, and they'd be thrown in the slammer for years, or the rest of their lives for carrying a little bit of cannabis. I think in Singapore, it's still like if you had more than a joint or something like that, it's death penalty. It's crazy.
Yeah,
absolutely crazy.
It's literally native. It's a native plant in that region of the world as well.
I think we've flagged, we won't say the guest name, but we are going to be doing an episode where we discuss some of these topics and the lasting devastating impacts of Nixon and Reagan and this so-called war on drugs. And I think it's certainly, I mean, the work that you do and the work that a lot of researchers and everyone in the medical profession who has come on board and embraced it as a therapy, it's just been so great to watch the transformation in Australia. I know that's only really been in the last 5 years or so, but the momentum is wonderful. We're at a really exciting time, in its history here. So and on that note, look, I think we'll leave it there, but I know that Mitch and I probably, 5-10 minutes from now, we'll have another 40 questions that will populate our minds.
That's why we've got to let him get back to his real life.
We'll let you get back to it, but if you're game to do this again, we would love to have a follow-up episode with you where we
put you on the spot right at the end, so you can't say no. That's the whole
No, that's been fun. I've had a great time, guys. Thank you. You asked some really good questions, and it's been a really fascinating discussion, so happy to come back.
Fantastic. Well, we'll get you on to finish the other 2 questions of what the most common questions you get asked, because I think we only got through one.
We only got
so much other stuff that it's just been an absolute wealth of information, and we thank you greatly on behalf of everybody who's going to tune in, and on behalf of us as well. So thank you.
Not a problem. Thanks for having me.
No worries, David. Thank you. We'll do this again soon. Take care.
Sounds good. Okay.
All right.
Cheers.
Bye.
Thank you.